anatomy, please feel free to go over any of the anatomical structures just to be sure. Nothing like this is really going to make an impact as we get into the specific diagnostics, other than to just make sure you have a general understanding. Okay. So I just add these slides just for that. So this goes through the eyeball structure. When we look at it, what we're looking at, there's 3 tissue layers: the ciliary body and the iris and the pupil is what we're looking at for the anatomy there. Then we're also looking here at the internal structures, which would be the retina, the vitreous humor, and the aqueous solution. And this is where we have some issues sometimes, because a lot of the treatments, and some of the treatments can go in and actually remove some fluid and give shots and do stuff like that. So we'll go over some of that later on. But again, if you feel like you have to review this, please feel free. If anybody needs some extra resources on any of this, also let me know and I can get that. Okay, I just don't want to bore you guys to death with anatomy because you guys already took anatomy. Our next slide here just looks at the physiology of vision and why we see, okay, how we see. Again, it's all about light, how we transmit the light, how we interpret everything, and it looks at focusing, nerve impulses, and perception. Perception is key in certain areas, so I do want to make sure you guys are aware of this, that there is a certain area that when we're looking at perception, some people may have perceptual differences, and in those cases, it's not necessarily an issue, it's more an issue with vision than it is with what they're seeing, if that makes sense. So it's kind of fuzzy right now to explain it to you. It's to say, like, if I look at a cord on the floor, it actually might represent something different to me. So for older people, as we start to look at, we want to look at the acuity, and that's why we want to minimize a lot of different distractions in the environment, because you might see something and misrepresent what it is. Okay, so that's when we look at visual perception and the differences with that. Talk about it a lot when I teach psych, because what I talk about is an illusion versus a delusion or a hallucination. Okay, so it's something that you're seeing differently. But we want to make sure, because a lot of times we're working with older folks, and you want to make sure what can they see, how are they interpreting what they see, and is there a clear field? Because if there's not, they're not seeing what we're seeing. There could be totally different changes with that. And we look at, of course, we can't go anywhere without knowing that when we look at any type of body system, we're looking at aging and how, as we get older, what's changing in there. So a healthy eye, of course, we have a clear lens, a large pupil, is very flexible. It's able to accommodate to light, and it's intact. As we start to get older, you'll start to see some thickening of the eyes, some cloudy lenses, sometimes there's a smaller pupil, sometimes the lens is more stiff, which makes accommodation more difficult, and that's why we start to see people having difficulty with vision overall. And the vitreous starts to disintegrate. And between 40 and 45, we start to lose a lot of the lens elasticity, making focusing difficult, and a lot of people at that time will require reading lenses. So it's not necessarily the ability to see far away at that point, it's the ability to see closer. Okay, so a lot of people will need lenses for that. At age 50 or 60 plus, there are a lot more significant changes. Okay, so there's the pupil size starts to get smaller, therefore there's less light entry. So the ability to see in the dark, as you guys can probably all do right now, becomes harder as you get older. Okay, you can adapt slower. So when you get up and you get out of bed, when you're taking care of older people and we walk into a room and it's a darkened room and you're younger than the person you're taking care of, it may be harder for them to accommodate and to be able to get out of bed and to see their way where you are able to do so. At about 50 again, there's decreased tear production. So we see a lot of issues with dry eye. Yellowing of the lens starts to happen at times, and the colors are not as bright or vibrant for a lot of people at that age. There also can be structural changes that we see. So the lenses start to thick, they start to get a little opaque. So that's when you start to see the cataracts and stuff like that. The vitreous gets a little liquefied. There's more corneal sensitivity. You have reduced visual acuities. Okay, so you're not able to see as well. You cannot tell the difference with contrast. And again, you can't differentiate from walking outside to inside. There's a harder time to adapt to the changes in the lights. Of course, when we think about that overall, is what I was talking about, is you have to think about the clinical applications of that. So, of course, if you are not able to see as well, if you have difficulty from coming into a light area, into a darkened area, there's an increased fall risk, the inability to see the area around you. Medication administration errors can happen with a lot of people if they're reading bottles or they're not sure. That can happen. And we start to worry about driving safety. So the ability to drive at night becomes very challenging for some people as they start to age, which does become very problematic overall for people, because driving we equate with being independent. So that's a little bit of a problem for people. This just goes through and starts to talk about the areas of the eye and how the different layers of the tissue. Again, more of A&P type stuff. So not necessarily something you have to be overly concerned with. And when we start to look at people and we start to look at how are we testing their eyes? Okay, so we take a health history always. Okay, because there are certain things that can hurt your eyes over time that may be something that's problematic. So do you work in an area where you might have gotten things into your eyes? Do you work in an area where you're a lot of screen time is problematic for people? Squinting, stuff like that. People who work outside, they don't wear goggles, different stuff. Okay, so there definitely can be issues with that. You want to start to ask other conditions too, medical conditions that might be concerning over time. You start to want to also look, are they noticing any changes? Okay, so are there any visual changes that they're noticing? Is vision more blurry? Are they seeing double at times? Do they feel like their vision has changed over time? Is there any changes in the dryness or the wetness of their eyes, so they have more issues with having to use drops? And we have to do a lot of teaching with drops, because sometimes people use drops for all different things. Over time, those drops can be problematic for people, so you want to have them minimize what they're using. And if they are using something, they're using something relatively benign. So like a saline drop rather than some of the other stuff that has additives to it. And then we want to, of course, test visual acuity. So the scale that she's holding is the Snellen eye chart, and we'll have the opportunity, hopefully, if we get back to campus, to work with one of those so that you guys can see. That's what we're using for adults mostly. Okay, you stand at 20 feet away, and then the numbers on the side would denote how well you can see at 20 feet away. So that's what we use for adults. There are other charts that we use for kids, and I'll go into that later on. But again, we want to test the visual acuity. That's just one way we test them, like in a doctor's office or so. But if you went to the eye doctors, of course, they have the other machines that they're using to look at your eyes and to make those differentiations. So we want to look at what we're doing and how we're assessing your eyes. And if we can do visual fields. Okay, so like you follow, are you able to adjust when you're looking close? Are you able to adjust when the person's further away? You have them at your nose, and you move your fingers to the periphery to see how far they can see and what the peripheral vision is. Then we look at the 6 cardinal fields of gaze. So we move your finger around. We then will do a corneal light reflex, where you shine the light on people. You can do the cover test. And then we do the pupillary reflexes, and we can do muscle balance with eye movements, okay? Those are different tests you can do. You're not gonna have to know all that. It's just to know what we would do, how we would test people to see, are they able to see in the periphery? Are they able to accommodate when we're moving our fingers around? Are we able to accommodate when our fingers going closer and further away? And how are people able to accommodate for their vision? Another thing that people often complain about when they start to get a little older is they start to worry about, or they start to notice floaters in their eyes. And people get, it can be very, very problematic for people, and people do get concerned with it. What happens is part of the vitreous breaks off and is floating around in your eye. It's a normal thing that happens. Over time, it's supposed to, your brain is actually supposed to get the messages that that's something that should be there. In the short term, people really do feel like there's something floating into their visual field. It might look like it's a fly, it may look like something different. But for people, it can be very, very problematic and very troublesome at that time. So you do want to do a lot of teaching around that it is something that's very common for people. It happens a lot as people get older, again, the golden years. And then what happens after that is hopefully you start to accommodate, and it's something you do not notice as well as much as your field of vision. If it is problematic or you start to notice a lot of them, you definitely should see your eye doctor more readily or quicker, because you can start to have some other issues. Again, this is just an adult eye chart. This is the Snellen chart. It's standard for measuring visual acuity and a distance. But if you can see what other people see at 20/20, they consider that to be perfect vision. That means at 20 feet, you can see what the average person can see at that point. And when you go down, the numbers are actually get larger. So you can see at 200 feet what people can see at 20 feet. So definitely, it's more problematic if you cannot see the larger numbers, of course. And people can do this with glasses or without, depending on, but if we're doing this without glasses or we're doing it with glasses, we should definitely be denoting that. This is a chart that we can use sometimes for pediatrics. Because some children cannot actually say numbers or whatever, or shapes or whatever it might be, or letters, sometimes they'll use these different symbols. Mm-hmm. A lot of times you'll see just the lines pointing to a particular direction, and you'll ask the child who is seeing it to point to that direction that the symbols are going in. And this also could be helpful for kids. It'll just be a different way to show. The different colors here just lets them also to know whether or not the children can see acuity, the difference in the colors. We also do intraocular pressure assessments, and I'm sure you guys are very familiar with those. If anybody's gone to the eye doctor probably over about 40 years old, they start to do pressures in your eyes just to see. And they'll test and see what the pressures are within your eyes. It allows you to, it allows them to make sure that the pressures are actually okay. The normal pressures would be 10 to 21. Again, is this something you need to know? No. It's just to know what they're testing for. If your numbers are above 21, we know that you're at increased risk for glaucoma overall. And that can definitely cause problems over time. So you want to make sure that we are telling people, and if people are getting toward the edge of those numbers where they're getting worse, we want to make sure we're doing more frequent testing. But usually once a year, they can do these tests. The risk factors for increased pressures would be a family history, of course, of glaucoma, African American, over 60 years old, people who are diabetic or have myopia, and anybody who's using corticosteroids over time. Okay, there is treatment for glaucoma, as long as we're testing for it and we can readily identify early. This just looks at, again, what types of testing we do for vision disorders. We do different imaging tests. We can actually look at the fluid within the eye. And then this gets a little dramatic here because we do have the little dog, which is a seeing eye dog. If you're needing a seeing eye dog, we've definitely missed the boat. But we could definitely want people to make sure that they're getting regular eye exams. We're doing eye hygiene. We're making sure that people are taking care of their eyes properly. If they're using contact lenses, that they're using them as they should be. So some people have the disposable the contact lenses, and they wear them for weeks at a time. We're also making sure that they should not sleep in their lenses, and make sure that they're cleaning their lenses. And if they're putting their lenses in, that their hands are actually clean. Making sure that their nutrition is good. We want to make sure they have antioxidants in their diet, leafy greens. And as I'm on this topic, you guys all are aware that vitamin D in leafy greens, just remember that for next week. Nutrition, again, that's what we're looking at. And then we're making sure eye safety. Protection. So we're definitely looking at safety glasses for people with chemicals, people who are riding motorcycles or bicycles, that they have something on so something can't get into their eyes. Polarized lenses if they can, if they're outside. And proper lighting. So I'm not sure if you guys are all relatively young, but you probably don't notice yet that what happens is as we start to get older, it is harder to actually accommodate and to realize that when you're sitting in the dark or you're sitting in a light area, that it can be more difficult to see in dark areas. So this happens generally over time. So you will start to notice that as well. So you want to make sure that people are aware that they should have good lighting if they're indeed reading or doing any type of activity that requires some acuity. Advanced or specialized measures, of course, there are guide dogs for people who are visually impaired. We also have multiple medications. We can close the tear drainage for severe dry eyes. They can do plugs and stuff to making sure that people who have their eyes are too moist or too dry, we can make sure we're doing that. And they can use eye patches. Eye patches are helpful for people in the short term, and overall, if there's going to be an issue, but not something we should be using long term if it's not necessary. And this is just a case scenario that I'll let you guys do on your own. Just something you can work through and just read through on your own. Not helpful. And this is now going to get into the outer ear. This is, again, just an overall issue that we're just going through and just looking at the different areas, and then we'll get into the actual specific diagnostics at a short term later. More AMP, looking at the outer and the inner ear. And again, something you guys are relatively familiar with, so I won't get into that. But just to look at it. If this is something that you're not familiar with, if this is something you don't remember from AMP, when we start to get into some of the diagnostics of it, you may want to review some, okay? But this is just looking at the different pictures of. Again, when we start to look at normal hearing, we start to look at changes that occur with age. And very similar to your vision, we start to look at how we start to lose some hearing over time. So at a young age, we would hope that everybody has relatively decent or good hearing. And presbyacus is what we have. It's age-related sensorineural hearing loss. It happens about to 1/3 of people, not until they're over about 60, 65, when you start to see more people requiring hearing aids for to make sure that their acuity is well. It does progress as time goes on, and it can definitely affect people's quality of life. If you guys watch TV, I'm sure lately, if people are watching TV, you notice that what they say is one of the new ads say that people who can't hear have a greater risk of dementia, or some loneliness and isolation. In a group of people, it can be really difficult for people to pick out sounds. So when we start to go into a hearing and acuity, we're going to look at the different hearing aids and how different hearing aids work and how they help people with not blocking out external noise overall. Okay, so about 40 to 50 years old, we see a subtle high frequency becomes a little less acute for us, so you can't hear as well. Sometimes it does affect your speech. And a lot of people will actually say at that time it goes unnoticed for them. At about 60 years old, you can definitely start to see some substantial hearing deficits. Speech understanding can be very decreased, especially with multiple speakers. That's what I was speaking about earlier. If you have external noise or background noise, younger people are able to block out external noise much more readily than older people. So it does become problematic when you're in more social settings for people. It can definitely impact safety as well. Between about 50 and 60, we have difficulty with noisy environments a lot of times. Sometimes you might notice people that they start asking for you to repeat things on and off. And then background noise does become less, it affects your comprehension, so you can't actually hear a lot with that. And tinnitus may develop for some people within their 50s. This is more common over time, and we're starting to see it a little bit more readily earlier in the years, though. It's not necessarily just at 50. So some people will complain about tinnitus earlier in their life. Probably about their 30s to 40s, we're seeing a greater prevalence of this. One of the questions that you may see on an exam, and it might not be something you see on our exam, but you might see it on the board exam, is what causes tinnitus, or what medication can cause tinnitus. And aspirin is one of the ones that they point out for that. For some reason, the board questions love that question. Other things that could cause tinnitus over time is loud noises. And a lot of people were actually complaining of some tinnitus with some of the vaccines as well. Some people were having some tinnitus after that. Tinnitus, although bothersome for most, can move on to be debilitating for many people. Over the course of the last few years, one person, I believe, I can't remember what restaurant he owned, but he owned a restaurant. He was diagnosed with tinnitus, probably in his 50s to 60s, and it was so bad that he ended up actually committing suicide because he said he could not function and he could not live with the constant ringing and the constant background noise that he was hearing. So when we talk about hearing loss, we talk about different ones, and one is sensory, and that's hair cell loss. Then we think about neural, and of course, when you think about neural, just think about nerve degeneration, and of course, neural and nerves. And then when we think about metabolic, there's some atrophy there, and then there's some mechanical, so that would be any different membranes or any areas of the ear. Important to know for people when we look at this, what contributes to hearing loss over time. When we look at different things, and we start to think about as a society what changes over time. When we look back, and I'm treating people now in their 60s or 70s, a lot of people will come in and they'll have excess cerumen in their ear, and they'll ask for like a lavage to get the cerumen out, and they'll start to have to wear hearing aids, probably in their 60s or so. And they're noting it to be a little bit earlier in life. A lot of people will put it off to be loud noises, concerts, things like that. And when we were younger, a lot of people didn't use hearing protection because a lot of the population I serve is the veteran population. A lot of them will end up with tinnitus and or hearing loss because of just different things that happen in the terms of their service. So it might be that they ran machine guns, or they were constantly around things where shooting was readily happening, or jet planes or something like that, where there was constant noise that's impacting their hearing over time. So one thing that I'm seeing now with people, and it's something that that people should be aware of, is that when people are wearing earbuds, if you're wearing earbuds and you have your phone and you're listening to your earbuds over time, what it'll do is you'll get some warnings on your phone, and the warnings will pop up and they'll say that you're listening to your music or your audio book or whatever you're listening to at a significantly higher level than you should be for a longer period of time than you should. And we'll give you the warning for that. But it'll be interesting to see over time how that changes. When we're starting to look at that, there are new modifications that are coming out. And when we're face to face in class again, I'll show you the different modifications we have, where it actually does bone conduction rather than actual going into your ear, and they actually are outside of your ear so that you can hear, and it's not readily available for everyone around you to hear, but you can hear without actually putting the device into your ear and causing issues with that. So again, when we look at what contributes to your hearing loss, again, is noise exposure, some genetics, any cardiovascular disease can cause such, diabetes, medications, and smoking. And what is the impact for people over time? Well, there is some social isolation because you're less common. You withdraw from conversation. You're not readily engaged, and you're not constantly speaking in the conversation or listening in conversation because you're not picking up half of what you should be. There's a greater risk for dementia, depression, and definitely for falls. Our next slide looks at how we look at data collection and what we're thinking about when we're doing data collection for people. We're definitely going to start to do, we do a hearing assessment. It is more subjective when people start to say they can't hear. A lot of times patients will play off that they can hear. So when we offer directions or we go through and we're doing some teaching with patients, that's why we like to do the teach back, not only just to make sure that they understand, but they heard what you said. Because oftentimes patients will just laugh or giggle when you're saying something or nod and as if they understood what you said when they're really not understanding at all what was said to them. So we like to do a lot of repetitive, make sure that they do teach back to you. We also want to do a health history. If somebody is telling you that they're having a difficulty hearing, when did it happen? What symptoms are they noticing? Did they have any ear infections in the past? Was there any trauma, any surgery? What was their noise exposure? So what did they do for a job? What did they do for recreation? Is there any family history of hearing loss? And we want to do a medication review because we want to look at different meds that could be ototoxic. And we want to know, are they using hearing aids or any assistive devices at present to assist with their hearing? A lot of the chemotherapeutic agents can be ototoxic as well. So a lot of times when we look at that, we do look at cost benefit. But we definitely want to make sure we know what the patient's using, okay? We want to make sure what is their hearing loss. Is it one ear versus both? Was it gradual or sudden? And again, if somebody's reporting sudden hearing loss, that's something that we want to immediately check out. Anything that's acute. So if something that just happened, we definitely want to look and see what possibly could happen, when it could have happened. So something obviously reversible, more so if it's something that's sudden. Tinnitus, is it ringing? Is it buzzing? Is it clicking? Is it constant? Does it happen only at certain times? And we want to know that. We also want to know if the patient has vertigo or dizziness. Do they have ear pain? Is there any discharge from their ears? Do they have like a full sensation? Is there a difficulty understanding speech? And can they differentiate background noise? And these are just different things that you're going to want to go over with the patient. A lot of times you have to give the patient examples. And we can go through and we'll do some of the we're going to actually do some hopeful stuff in the lab to go over how we would actually test people. How we look at this and how it affects people's lives are definitely more problems with phone communications and conversations. Again, as we start to think about cultures, a lot of people now are texting instead of calling somebody. But sometimes when people are using the telephone, it can be more difficult to hear. They'll start to avoid more social situations, need to increase the TV, the radio volume. They'll frequently ask for repetition of things. They can have hard time looking for for the noise direction. So if you're trying to differentiate what's making noise somewhere, they'll have a hard time differentiating where it is in the room, where it is in the house, all different stuff with that. it can definitely have a significant impact on work, performance, and relationships, because you can't hear, or you're constantly asking people to repeat themselves, or you feel like it's embarrassing because you have to keep asking people to repeat themselves. So it can cause a lot of issues over time. We want to make sure that people feel well enough or comfortable enough to discuss this with us. When we're looking for objective data, we're looking at the external inspection. We're going to look at the auricle for size, position, symmetry. Is there any lesion? Is there any deformity? We want to palpate for tenderness. We want to see if there's any nodules or swelling. Is there any drainage from the canal? We want to assess for battle signs, so ecchymosis behind the ear. Of course, you would know that they would have a head injury at that point. Then you want to do an otoscopic examination. You want to pull the auricle up and back if this is for adults. That's to straighten out the ear canal and allow you to visualize clearly the tympanic membrane. It should be pearly gray and translucent, and there should be a little bit of a cone of light. When you look at it, it should be almost shiny and opalesque. In looking at it, there can be color changes, and definitely you can see some color changes with different issues. There definitely can be issues with perforation, some bulging at times, some retraction or scarring, and you want to look in the canal to see if there's any cerumen. If there is cerumen in the canal, you won't get a good examination. And so you can go through and actually do a lavage and hopefully try to remove the wax, and or people can use drops to remove the wax and then be able to see. But you do want to be able to clearly visualize the tympanic membrane in order to make an assessment for hearing loss. You also can notice for foreign bodies, inflammation or discharge. When we're talking about foreign bodies, one of the things that are more commonly found in people's ears, believe it or not, are the tips of the hearing aids. We had a gentleman who came to the clinic, said he was noticing some hearing loss, specifically in one ear, and said that he noticed it over time, and he felt like there might be wax in there, or there might be something else going on. And he's like, I'm going to have to bring these hearing aids back because they're not working as well as they had been. When we looked in his ear, there were actually 2 plugs from the tip of his hearing aid in his ear. So we do want to teach people when they are putting hearing aids in and out of their ear that you're looking at the entire instrument to make sure that it's intact when it's coming out. And again, something you can easily take out. Sometimes it's too close to the tympanic membrane, though, so you're not able to grab it without special instrumentation. So they might have to go to an emergency room or to an ENT just to be able to remove that. We do different hearing tests. One of the more common tests that they use a lot of times, and if somebody's going for a commercial driver's license or something, is a whisper test. And the whisper test is just whispering something to see if the person can actually hear it without reading your lips or looking at you, and to be able to repeat that. They also do the RIN test and the Weber test, which is we'll see on the next card. And you want to watch the patient's behavior. Are they leaning forward? Are they watching your lips? Are they responding inappropriately? Are they speaking loudly? Generally, if people can't hear as well, they will speak more loudly. And always we want to know, are they using hearing aids? And what is the effectiveness of the hearing aids? Hearing aids are good, and we'll generally replace them every 5 years, depending on how the hearing progresses over that time. There are some that are actually fitted to the actual ear, are there molded hearing aids, which are beneficial for patients, and some others are just the tip goes in, and those are worn outside of the ear. There are a bunch of new ones that they're coming out with that are more stylish for people, but those are the more common ones you'll see. And I think I have a picture of them later on in the slides. We'll also do a balance assessment, which is a Romberg test. And we'll just check that for vestibular function. You watch for gait and unsteadiness. You watch their eyes. And you want to also document any complaints of vertigo or spatial disorientation. Some people will report a more full feeling to their ears, or you can see if there's just excess fluids within their ears. And some people, it can be just as easy as taking an antihistamine. Can actually help people who are complaining of some fullness. But you want to make sure that there is no infection at that point as well. And this is just telling you here how we're doing the different tests. So we have the Weber test, or we have the whisper test. Again, what we would do is you'd stand 1 to 2 feet from the patient, you would whisper something without looking at them. And then have them repeat what you had said back. And if they repeated it correctly, of course, it's a positive, and an abnormal would be if they cannot. The Weber test and the Rin test are again using the tuning forks to determine whether or not they can hear. And we'll do this again in the lab. It's more easy to show people in the lab. We'll actually ting it. You actually hold it on the top of their head to see if they can hear it, or you would hold it close so that they can hear it next to their ear. The idea there is that they should be able to hear better than just the bone conduction. But again, that's something we'll do in the class so that you guys can actually use the instrumentation. The Romberg test is merely you just have the patient stand while you're balanced, making sure that they're balanced. They'll close their eyes and see if they're able to stand while you're doing that without losing their balance. That's something also we can do when we're in the lab together. This just shows different testing we can use for hearing acuity, as well as the otoscope. And here are some medications that we have. Many of these, I don't want you guys to memorize these medications, okay? I don't want you to memorize what they're, the different names or the different, anything with them. If there's something that you must know, I'll definitely make sure that we are covering that in more depth. But we definitely have anti-infectives for otitis. We can give different systemic medications. We can give topicals. We do a lot of teaching around this. And of course, a lot of the teaching, because it is an anti-infective, is very similar to any antibiotic we're giving anyone. We make sure that the patient is taking the full dosage. So complete the full course. Even if you're feeling better, we want to make sure that you're maintaining the whole course of the medication, so that next week when you have something wrong with your ear, you can't say, I'm going in the medicine cabinet to take out the medication that I took last time, because that will obviously work. There should be nothing left over. If there is anything left over, it should be thrown away, and we should get more medication the next time you need it. But your antibiotics should be a full course, completely taken. If your symptoms continue, you definitely want to make sure that the doctor is aware. When we give people topical drops, we want to make sure that they are warm to the body temperature, so we're not putting something cold in someone's ears. We want to make sure we're pulling the auricle appropriately for the age. So are we pulling it up or down, depending on whether it's an adult or a child, to make sure we're straightening out the ear canal. And we want the person to remain lying down for about 5 minutes after we've given the meds. For anti-inflammatories, again, we can a lot of times use corticosteroids, and that just reduces any swelling. If we're giving steroids, most times we're giving antibiotics with those, and they're a combination. We would never put anything in someone's ear or do a lavage if somebody has had a history of membrane perforation, okay? Because we do not want anything that we're putting in somebody's ear to be absorbed systemically, okay? And then we can also give NSAIDs if we're doing stuff that's more systemic. Antihistamines, of course, we can give Benadryl. And that, of course, we're using those if people have middle ear effusions. It can cause a lot of side effects. We know that. It can make you tired. It could also cause dryness. It may thicken your secretions, and make sure that people are, of course, drinking enough. For older people, you want to be aware, because when we are giving any type of anticholinergics, it does have a significant drying effect, especially on older people. So this is definitely something that's more prevalent when we're giving it to older people. We want to make sure that they're aware that they should be drinking more, and that it will have a drying effect. We can give decongestants, okay? And that, again, stops with the congestion. We want to use it cautiously with people with hypertension, any cardiac disease, any BPH. It can cause insomnia, anxiety, but it should only be used short term. This is something that should only be used about 3 to 5 days. We want to make sure we're teaching patients, because patients oftentimes will think that if you use it for 3 days, that's great. I can use it for 6 days. That's even better. So we definitely want to make sure that patients are aware that they should be using things specifically for ears only as prescribed, because it can have problems over time. We also have the medications we can use to decrease the cerumen. A lot of people will use peroxide. And when we're doing a lavage, you're just using peroxide in water. But for some patients, because they'll use the other drops, they can be costly. So if they are costly, some people will use mineral oil too. And that's something that's relatively cheap and that they can use all the time. We like them to use the medications before irrigation. And what they'll do is not necessarily just 15 minutes before irrigation. They'll use it for several days. They'll put them in at night with cotton balls and take out the cotton balls in the morning. And we say to use them to 3 to 5 days prior to an actual lavage, and that will actually help the wax come out without having it hardened in there. We don't want to ever use drops or anything like that if the person has a history of perforation, if they have tubes, if they've had any recent surgeries, if they have drainage in their ears. And we want to make sure that if people do have canals that are very narrow and or windy, that you want to make sure that the actual drops are getting into the area where the tympanic membrane is. So sometimes placing a little bit of pressure on the outer ear and just rubbing it in is beneficial for people. So that's just some more teaching for people when you're giving medications. Diuretics, people who have Meniere's disease, because they have the increased pressure, sometimes diuretics can be helpful. We want to always watch, if you're giving somebody diuretics, we of course want to watch electrolytes, specifically potassium. We want to make sure that we're not giving them medication that's going to cause other issues, because if they have Meniere's disease and they feel like they're dizzy, and us adding more of like a Lasix or something to them could actually cause more issues with blood pressure and cause more falling or any issues with balance. And we want to make sure that they are maintaining a low sodium diet. That's probably one of the better things for them to do, because then there's not the increase of fluid in their system. And again, any of those treatments can take a significant amount of time to become effective for people. So we want to make sure we're doing a lot of teaching around that. So it's not something that's going to be immediate help for them. For this one, let's just do it anyway. Mrs. Tanner, she's a 68-year-old female. She's admitted for elective knee replacement surgery. During her initial assessment, she reports a feeling of fullness in her right ear. She has dizziness, especially when changing positions, and she's occasionally feeling unsteady on her feet. You perform a Romberg test and demonstrate significant swaying when her eyes are closed. So when you put your hands, when she stands with her eyes closed, she's unable to maintain her balance. What should you do in response to these assessment findings? So when we look at it, it does say that, of course, she is got the fullness in her ears, she is dizzy, and she has the positive Romberg. So she does have some vestibular dysfunction. Why would that be problematic if she's going in for a knee replacement surgery? Anybody?
You ask it again, I missed it.
Why would we worry about balance if she's going in for a knee surgery?
Because we need her up and trying to walk around after the surgery.
And we don't want to break
that. We don't want to break a hip.
We don't want to break a hip or screw up our knee, right? Okay.
Yes.
Yeah. Okay. So we will do sometimes. This is something that's important. Okay. So we want to make sure that there's not going to be a problem with balance. And we're also going to be giving her pain meds, and she's going to be starting to walk on this new knee. So her balance is going to be probably more greatly impacted. So this is something we definitely would worry about. We could worry about Meniere's disease. She can have neuritis. She can have vertigo. So we definitely want to make sure, and we might want to have ENT see her before the surgery. Good pickup, guys. And again, this just goes over the answer and what we would do. Well, of course, the safety interventions we would do, we would make sure that we notify the surgeon, make sure the primary care provider is aware, we make sure anesthesiology is aware, and we want to make sure physical therapy is aware, because physical therapy is always going to be the first person who gets your knee surgeries out of bed. Okay. And we want them to be more cautious. So if they go forward with the surgery, we do want to make sure that the patient and the family is aware that this is something they should definitely be, keep an eye on as they're getting, as she's coming out of surgery. This is a picture here of a type of hearing aid. And this is when I talk about the tips possibly getting stuck in people's ears. It's the small area at the end here, and I'm pointing to it like you guys can see, but it is the little clear area at the end, and some of them are black. So when people forget them and leave them in their ears, some of them can be very, very small. And I think what happens is the dexterity of people when they're starting to put them in their ears and to do that type of thing, sometimes they feel like they fell off and they might have fallen on the floor and they don't realize that it was still in their ear. So it's important to make sure that the patients are aware that this is something that happens a lot. And because of the dexterity and because the way that they're made, and they're made to come off pretty readily, that we make sure that the patients know to inspect the hearing aid when they're taking it out. Just because we want to make sure that it's not, of course, if you're sticking 3 of those little tips in your ear, the hearing aids are not going to work as they should. And definitely hearing aids, and again, these are the types that actually go outside of the ear, and the tip just goes into your ear. But there are some that are actually built and molded right to the inner ear. There are also different types that you can actually use, and you can change the hearing and the acuity of it by just on your phone. Some of them have an app. Some of them have the buttons on the side. Make sure that when we're, if a patient does have them or they're going for them, it's something that's suitable for the patient. If they're not very tech savvy, it might not be beneficial to have something that has an app on their phone. Also, if there's something that requires a lot of dexterity, it might not be helpful for people either. So it's great to have the hearing aids, and they can be costly, up to $5,000-$6,000 at times. So you want to make sure it's something that fits within the person's lifestyle and what they're comfortable with, because you want them to be able to use them. Otherwise, we've missed the boat, essentially. And getting them for somebody, it's just a big waste of money. We also have cochlear implants. Those are helpful for people as well, but again, require a lot more invasive treatment for that. We also have hearing service dogs, of course, for people. And then we have communication support, which is just, when we look at it, even just talking to people, it can be helpful. Assume that a lot of your patients are hearing impaired, and when we sit to talk to people, we want to sit at approximately the same level. You want to be facing the patient when you're speaking. You want to speak slowly and clearly and make sure we're enunciating. And oftentimes when we're in a patient's room, we're multitasking, because as nurses, that's what we do. We're on our way to do something else, and you may have your back to the patient, or you may be doing something when you're talking to the patient. And it can greatly improve communication if you're actually sitting and speaking with them. We can definitely get amplified phones for people. We can get TV listening things. Some TVs now, instead of having the TV all the way turned up, you can actually get a little device that's like a box that the person can put by their bedside, which is like a little speaker that actually amplifies the sound, so it doesn't have to be so loud. But it can be more loud for them, but not for everyone else watching the TV. There's definitely vibrating alarm clocks that they can use. Sometimes there's a flashing doorbell. In hotels too, they have the flashing lights that you can have so that you know somebody's there without having to listen for a knock or something. There's the telephones that they can use, the text ones. They have video relay ones now, captioning on everything. And we can definitely get interpreters for people who are hearing impaired as well. not gonna get into that one. And this is just an S bar. I let you guys look at that on your own as well. Again, it's just how you would report off. It's something you'll get very common or very comfortable with over time. It's just a way to give report. And this also is just another way to say that there's an issue and to report that off. And I'll let you guys look at that too when we're together. Okay, here's the question for you guys. Which of the following techniques or components of the, I can't even read that because my eyes are getting worse because I'm getting old. Hold on.
Comprehensive visual.
Thank you. Thank you.
Acuity assessment, select all and apply.
Okay.
Visual fields by confrontation, whisper voice test, 6 cardinal fields of glare,
Gaze.
maybe? Gaze.
Gaze. Yeah.
Remembering test,
The Romberg test. Yeah, that's okay.
pupillarity light reflexes, command light reflexes, Hirschenberg test.
Yeah. Corneal light reflexes. Okay.
Well,
Anybody?
you could show off, Chris, that you can read things. The rest of us
Yeah,
can't.
I can't read that.
I'm trying really
Which is
hard.
pretty
it's really
bad.
little.
It would be larger in the classroom, Lee.
So what are we looking? Oh, that one's better. Can we skip number
That was
one?
much
and
better,
just go-
yeah, but that's not all right, that's our next one.
All right. So what are we trying to look at? Following techniques are components of a comprehend. Okay. So we need to look at the visual stuff. So A,
Visual fields of confrontation, yes. A whisper test is not, it's for ears.
no. The 6 cardinals of gaze, that probably counts because we're
Yep.
gazing at shit. It's the eyes. A remembering test is not going to help your eyes.
No.
The light reflexes, yes.
Yes, and
And
the
then
corneal light reflexes, right?
Yeah, we want all those.
Bam, okay.
Thanks, sir.
Yeah, there we go. Correct answer is visual fields by confrontation, pupillary light reflexes, the cover test, the 6 cardinal fields of gaze, and the corneal light reflex.
We got it right, gangster. We're
Yay.
all amazing.
At least you could read it, that's all I can think. Okay, the nurses to gather subjective visual patient data, what action should the nurse take? So, should we ask about current symptoms such as pain or visual changes?
Yes.
Yes.
Should we inspect the external eye structures?
Yes.
Should we inquire about the family history of eye
Yes.
disease?
Yes, because that counts.
Should we measure visual acuity using the Snellen chart?
Yes.
Sure.
Sure we should. Should we
Right.
document the patient's description of visual disturbances?
Yes,
And should we perform pupillary light reflex testing?
Yes.
definitely.
And review medications that affect vision?
Yes.
Always.
So what is our answers?
All of
Well.
the above.
Well, this is where, you know, why? What is the key word here that might catch us up,
Oh, subjective, motherfucker.
right?
Oh,
Yeah,
Thank you.
we fucked up.
So
We
let's see what
fucked
they
up.
say. They are saying, we're gonna ask about current symptoms, we're gonna document the patient's description, we're gonna inquire about family history, and we're gonna review medication. The others we would also do, but they were objective, not
Not
subjective.
subjective. See, we got to read the question, guys. Do better next time, class.
Yeah, okay, whatever. Okay, the next one, multiple choice. Which diagnostic test for eye disorders would require the nurse to ask patient about dye allergies prior to the test? We didn't really do this one, did we? I don't think we even covered this. Which one do you think it is, though?
Number
Electroretinopathy?
C.
No. Electroretinography is just taking a picture, right?
Yeah.
The-
I think it's C, right? Isn't that,
It's
that
C.
sounds like something you do
Yeah.
some shit to, right? Okay.
Yeah, that's angiography. So we're putting stuff in there. So our correct answer, yes. It's the angiography because it's a dye. Okay. Many times these dyes, though, may not be something that they're allergic to, but we definitely want to make sure that we're aware so we can give a pre-med if we have to. The patient reports that they can't hear with his hearing aid. What should the nurse do? Should we check if the hearing aid is turned on?
Definitely.
Should we verify the hearing aid battery is working?
Absolutely.
Should we use a cotton swab to clean the inside of the ear canal?
Never.
Never,
Never.
nothing, okay, no matter how many times we all use cotton tip swabs or whatever we use in our ears to clean them out, we are never to tell a patient nothing smaller than your elbow in your ear, okay? So just make sure that patients are not sticking things in their ear.
None of
Should
that
we inspect the
nonsense.
hearing aid for cerumen blockage?
Definitely.
Yeah, so the part where we talk about where the little tip goes in, it's the little plastic part. Sometimes wax will get inside that area and it won't let it won't let it adhere properly, essentially, for better word used there. Should we remove the hearing aid and soak it in hydrogen peroxide?
No. I
Nay.
don't know, maybe.
Okay, no. Never put the hearing aid in anything wet.
Liquid, right? It's electronic.
Yeah. So you don't want to
Oh.
definitely put an electronic in the hydrogen peroxide. Hydrogen peroxide can be used in the patient's ear. But even after you do a lavage, you clean someone's ear, you want to make sure the ear is a little bit dry before they put the hearing aids back in. Should we ensure the hearing aid is properly positioned in the ear?
Yes.
And should we check the settings to make sure that they can hear?
Yes.
Yes, okay, so you guys did fine.
Oh, genius.
Genius, rocket scientists here. The nurse is assisting with a Romberg test. This is one where we're standing up and you're having the patient close their eyes. Generally, you put your hand in front of them and behind them because you don't want them to fall over. But, oh, well, that's probably silly. Okay, well, here we go. What action should the nurse take for safety? Have the patient stand with feet wide apart?
Yeah,
patient-
that helps.
Huh?
That helps, right? When you're
Yeah, it
super
can
wide,
help.
you're less likely to fall
So it
over.
depends how wide. Definitely want to have a wider stance though, because the more narrow that they stand, the easier that they're going to fall over. Ask the patient to close their eyes and extend their arms forward. Not always that. Stand close enough to catch the patient if they begin to fall. Instruct the
Definitely.
patient, instruct the patient to walk in a straight line with their eyes closed. No. Have the patient stand with one foot with their eyes open. No.
Sounds like a
the
DUI
correct
test.
answer,
What's going on here?
make sure that you're standing, so that you're ready to provide support if they are going to fall over. And again, you want to make sure that as soon as they start to wobble, that you're there just to essentially just to have them open their eyes and make them brace themselves. Because we know that we're not going to pick up people. We're not going to catch somebody if they're falling over. Eardrop administration, just a little how we do it. You make sure you verify the order, right patient, we're doing our rights on that one. You want to check for any contraindications. And again, the technique would be age specific. So do we want to pull the auricle back or down? So we want to pull it back and up for adults, because you want to straighten out the canal. For children, you want to pull it down. Okay. And then you want to make sure that you're making sure the medication is warm or not hot, but warm enough so it's not going to be problematic for them. And after you administer, you want to make sure that the patient remains lying for up to 5 minutes. Some people will actually put their finger on that one area of their ear just to make sure that it does actually go in. You want to teach them for home administration, possibly warming the drops, proper positioning, staying still for 5 minutes, and the full course of medication. And again, if you have to do it bilaterally, they would put 5 minutes on one side and then 5 minutes on the other side. And then you want to watch for any ototoxic medications and make sure we're documenting as such. And this is just clinical pearls for vision and hearing. Do you guys have any questions?
No, I think we're good.
No questions.
No, no questions?
No.
I'm gonna go over it all. I'll go over it all again and I'll make sure we're gonna have a review prior to our exam anyway. And we're definitely going to, I'll definitely do a voiceover for some of these too, rather than rush through it all. I want to go over, on the new, did you guys see on the Canvas site? I do have a lot of these in here. I'm gonna open it up now so you guys can see. When you get into the module, which is module 9,
Oh, all your little sheets you put in there? I did see those.
yeah, there's a lot of videos, okay? So I did put a lot of videos in so that you guys have them. They're very short, okay? So these are all really short videos, but there's an anatomy video, which is just helpful to go over what is myopia. As people get older, of course, they end up with more blurry vision, different eye diseases, and it does a visual simulation. Some of these are cool because they let you see how the patient sees. It talks about smartphone blindness, because all of us use our phone, how screen time affects our eyes, what is hearing loss simulation. Again, it goes over how people hear and how we notice stuff. Hearing loss simulator, how to protect your hearing, stop cleaning your ears, and how to administer eye drops. Then you also have your PowerPoints in there. And there's this, which is a discussion, okay? So in your spare time this evening, when you guys are going over your videos, so make sure you watch your videos, this is a case study, okay? All I want you guys to do is read it over, what's going on with the person. That I did over here, your task, I guess, is to reflect on his experience and the responses. How does he feel his sensory defects are affecting his ability to participate in his care? Discuss at least 2 nursing interventions that could support his safety, autonomy, and engagement. And then explain how you would adapt communication and teaching to meet his needs. Don't make these long, guys. Just short. 5 to 7 sentences is more than enough. Post your response, reply to one person, and you don't have to do it all tonight. It can be over the course of the week, okay?
So when is this due?
You guys got till next week, or
Okay.
till we have our, nothing like, don't worry about, you'll have plenty of time to do it tonight. Please, 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 do not feel like you have to go in and do major stuff. All it is that we can do it right here. He has advanced diabetic neuropathy. He was admitted after a fall. He's got vision loss. He's alert and oriented. He appears withdrawn and frustrated. He often misses meals and medications because he doesn't realize that they've been delivered. So that means that people are coming in and putting them on his bedside table and not telling him that either his meds or his meal are there, which is a damn shame in itself. He struggles to locate the call bell and navigate his room. He frequently declines assistance, saying, "I can manage on my own." So, how do we identify that his sensory defect is affecting his ability to participate in his care? Well, he's not taking his meds. He's not eating at times. He's more frustrated and withdrawn, so he's not really engaging in anything around him. And he's not asking for help. And he can't even call for help because he can't find his call bell. So there's a lot of that that's going on. So it's definitely affecting his ability to participate in his care. 2 things we could do to support his safety, autonomy, and engagement. So we could definitely make sure that he can reach his call bell every single time we leave the room. That's one intervention we can use. Autonomy, we want him to make his decisions, okay? So we want to respect the idea that he wants to be as independent as possible, but we also want to make sure that he's safe. So what can we do to engage, to improve that? And how can we get him more engaged in care, okay? And how you would adapt communication or teaching strategies to meet his needs. 5 to 7 sentences. You guys can probably do this in 5 minutes flat, okay? So don't get too caught up in it. Just go through and get, just get your thoughts together, what might be helpful, post it on there, and then take a moment to look at somebody else's replies and just reply to one person. Could be some that's exactly the same as yours, could be something that you didn't think of, could be anything, okay? But don't make a lot of it. I don't want you guys to get stressed over it. So like, don't say, oh my God, when does it due? I have to write a 3-page paper. No more than 5, okay? No more than 5. Like, what would you do? And think about it in your daily care. If you walked into a clinical setting and noticed that, what would you do? One of the basic things you should do is when you walk in to drop off anything to a patient is to make sure that you know that you're there. You're announcing yourself when you're coming into the room. So, I mean, that's just one intervention. That could be just make sure people are announcing themselves. Make sure that everyone's aware that he has an issue. make sure that the call bell is always within his reach and that he knows how to use it. Okay, maybe make sure, I mean, we could probably get stuff in his room that he could see better, so maybe something would flash when you come in the room. Maybe there would be something that makes a noise when you come in the room. Okay, whatever you think would be helpful for him. Okay,
Sounds good.
sounds like a plan, guys. You are good
Sounds
to
like
go.
a plan, Stan.
Yes, you're good to go for
I'm
the
good.
evening as soon as I know. So tomorrow we'll meet briefly and I'll have the voiceover PowerPoints for you guys.
Okay,
Tomorrow we'll meet briefly just to make sure we can get an attendance taken, and so we give you guys credit for that. As soon as I know when the test will be, I will get back to you guys.
okay.
Okay?
Did you say that I was here? Because you said that somebody didn't have a clear thing, but it was mine.
It's
That was
yours.
my
That's
fault.
okay. I got you.
Yeah, it's Janice.
Okay. I see that there's 23 of us. There's 22 in the class, right?
Yes.
Mhm. So that we're all here. Okay?
Awesome sauce. Thanks for an awesome night.
No worries. Have a good night, guys. Be
Good
safe when
night.
you're going out.
Good night.
Okay? Good night.
Good night. Thank you.
Have a good night.
Bye.
Thank you. Good night. Thank you.
Thank you.
Bye.
Good night.